Okay. Hello, everyone, and welcome to another session of the Surgical Fix Series, Volume 2. Our session today is a continuation of the Bariatric Week, and our session today is titled Endoscopic Adjuncts in Managing Complications of Bariatric Surgery. The session today will be presented by Dr. Jaber Al-Ali. Dr. Jaber is an associate professor at Kuwait University and also a consultant gastroenterologist at Mubarak Al-Kabir Hospital. Dr. Jaber completed his residency in the American Board of Internal Medicine, and then he completed a fellowship in adult gastroenterology at the University of British Columbia. Dr. Jaber, it's a pleasure to have you here with us today. Before we start, I would just like to note that if anybody has any questions, please don't hesitate to leave them in the Q&A section, and we will get to answering all the questions towards the end of the session. Also, if you'd like to register for any of the Surg Kuwait sessions, please refer to the chat feature. Dr. Jaber, thank you again for joining us today, and we look forward to this session. The floor is yours. You may start.
Thank you so much, Dr. Noor. First of all, I should say thank you to the organizing committee. Thank you, Dr. Noor. Thank you, Dr. Ali and Dr. Mohammed, for this kind invitation. It's always a pleasure to share my knowledge and expertise in certain areas with all of you. And thank you also for attendees who is really sparing some time to be with us today. So today I will be talking about a very interesting topic, very interesting area in bariatric and post-bariatric complications, which is the endoscopic field. So I'll be talking about in general some of the complications, how gastroenterologists or endoscopists can be involved in treating patients with post-bariatric surgery complications. So I will start with this slide. This is a very old slide that I have, just showing the most common type of bariatric surgeries in Kuwait, including the adjustable gastric band, followed by gastric bypass, and then a very common bariatric surgery that we all know is laparoscopic sleeve gastrectomy. In 2011, in Kuwait, about 6,500 cases of bariatric surgery being done, and that was the area of a very common time that we saw a complication from these type of surgeries. But thanks God, I should say that right now everything is improving dramatically. Even the knowledge, the way of how doing this type of surgeries, the way of handling the complications, it's totally different. So with regards to the complication, there is a common complications that to all bariatric surgeries, including like gallstones, peptic ulcer disease. A very common right now, as a gastroenterologist, I do see cases with gastroesophageal reflux diseases, mainly and specifically after laparoscopic sleeve gastrectomy and adjustable gastric band cases. There is certain complications that we see after gastric banding, like GERD. We do see food impactions. We see either a band displacement or erosion inside the stomach, and we will see some of the slides that we will talk about later on. With regards to the gastric bypass surgery and sleeve gastrectomy, we do see ulcers at the anastomotic area can cause bleeding and perforation. We do see a stricture and twist, either with gastric bypass or laparoscopic sleeve gastrectomy. Leak, this is, we will spend a good time talking about the leak and fistulas. Weight regain is another issue, either after laparoscopic sleeve or a gastric bypass, which is more difficult to deal with. So if we are talking about these complications, as a gastroenterologist and as a surgeon, we need to know that if we need to deal with these type of patients, we have to choose the right patient. So if as a gastroenterologist, if you are not comfortable in this zone, I think you should send your cases to an expert or experienced surgeon who can deal with these type of cases, because they are very sick and complicated cases. You should have an experienced surgical team who dealt with bariatric, in general, bariatric cases and bariatric complications. You have to have a very knowledgeable, talented, experienced radiologist who can pick up a very minor complications that sometimes is very, very difficult. Anesthesia is a very important because these patients are extremely or morbidly obese with multiple medical issues. So when they are sick, they are really sick. So you have to have an experienced anesthesiologist who will be beside you to deal with this type of patient. As a gastroenterologist and endoscopist, you should have a fully equipped endoscopy room. For some cases, you need a fluoroscopy to deal with these type of complications. And endoscopist, not every gastroenterologist, with my full respect to everyone, can deal with these type of cases. Don't forget about nursing staff because they are very important. They have experience. If they are dealing with these type of cases, they can share their knowledge with you. They can support you during these type of cases. So you have good endoscopy, you have good anesthesia, you have good, all what we mentioned before. But what about the toolbox? The toolbox is very important. You cannot do any procedure endoscopically if you don't have a fully equipped room, or what we call it a toolbox. So you should have a diagnostic and therapeutic and pediatric endoscope. The reason why, because sometimes you cannot even insert your scope with a normal scope. So you should go and switch to a pediatric scope. Therapeutic scope is always as needed. You should have an endoscopic cap. For some people who does not know what is the endoscopic cap, we place this a rubber cap at the tip of the scope just to improve the visualization of minor or settled abnormalities like a very tiny leak or very tiny perforation. This will magnify the view for you and you have a better view. You should have a different size of dilatation balloon. You should have a CRE balloon. When we say a CRE balloon, it's basically from 5 millimeter to a 20 millimeter. And you should have an achalasia balloon, which is 30 and 35 and 40 millimeter mercury for certain cases. So you should have this is available. You should have a suturing scissor because sometimes with a tension at the anastomosis, because it's causing ulceration at the anastomotic area, you need to cut this. So should be available. Hemostatic clip or endoscopic clip should be available for bleedings, for maybe a minor perforation, but it not being used for, or do not use it for a post-laparoscopic sleeve leak. All these type of cases should be done with a CO2 insufflator because it's going to take time. So it's better and safer for the patient, especially if you are thinking about leak or perforation. It's better to use the CO2. Grasping forceps, foreign body retrieval, cytology brush if you want to enhance granulations and healing. So you should use the cytology brush, different type of snares, and biliary dilatation catheter if you want to inject in a certain area rather than gushing the contrast everywhere in the stomach. Over the scope clipping system, I have a very good slide. We use it also for a leak perforations. Esophageal stent, you should have a variety of the stent. Again, we will talk about this. This is the mainstay to treat patient with leaks. Organoplasma, this is very important for a weight regain procedure that we will show. So let's start with the structure that we see either with after Roux-en-Y or after laparoscopic sleeve. Roux-en-Y surgery, it's a stoma structure. It can usually happen within the 2 months of post-surgery. Not that often we see it. The reported cases of major series is about 4 to 8%. These type of patients, they present with nausea, with vomiting, food regurgitation. They have pain while eating or immediately after eating. These type of patients need to be imaged either by a barium meal, or you can do endoscopy to evaluate the case and you evaluate the stricture. The best way of treating these type of patients is by through the scope balloon dilatation, which is a very successful. It can reach up to 85 and 100%. It's a very successful. Sometimes we don't do it once, so we do gradual dilatation. The reason why, because you don't want to perforate the patient, so we dilate slowly, gradually, 2-3 sessions. Most of them, they do very well within 2 sessions. If the patient comes very late presentation, after 3-4 months of the stricture, this will be a lower successful rate because you need to dilate more and more. This will increase your risk of perforation if you dilate these type of patients. So you have to be really very careful with these type of patients, but they do respond very well if you catch them early, if you interfere early. Do not dilate the cases within the first month, because this will increase your risk of perforation also. For refractory cases of stricture, you can stent these type of patients. Stent can also be a very good option, but the risk of stent migration is high in these type of patients. So you have to choose the right modality of treatment. Either you dilate or you stent, and if you want to stent, you have to choose the right stent for these type of patients. So this is another issue. This is a very complicated that I see a lot of these type of patients who end up with post-sleeve stricture or a twist, usually at the level of the incisura. In the literature, they say it's 0.5 to 1.5. I think it's higher than this. At least what I see, these type of patients at risk to develop leak because of the severe twist or angulation at the incisura level. You do not dilate this patient. Sorry, this patient, they present also with abdominal pain. Some patient, they will say, when I eat, I feel the food is stuck in my lower chest. I feel nauseated. I have to put my finger and vomit to feel some sort of release. Some patient, they manipulate themselves. They jump. They sleep in one side. Just they think mentally that this will improve their swallowing. Some patients, they present very late because they think this is an initial presentation or this is a normal presentation of sleeve gastrectomy. These type of patients need to be managed by barium meal and endoscopy. Some patients, you will not catch them with a barium meal, specifically if you don't have an experienced radiologist. He will not be able to catch the twist or the angulation. They think this is a normal post-sleeve finding. And this patient, they don't do very well with through the scope balloon dilatation, i.e. they don't do well if you dilate them with 15 millimeter or 20 millimeter. We saw cases that's been dilated with this. Trust me, it's useless. Do not do this type, or if you see your patient has been dilated with this is not right. So the best way of treating these patients is with an achalasia balloon. You start with a 30 millimeter mercury. This is the first session. I do 30 and 35. I bring them after 2 weeks with a 35, and rarely I go with 40. The reason why rarely, because the risk of perforation will increase very high if you use 40 millimeter mercury. It's a very successful procedure. The successful rate is 87-88%, specifically if you do it gradually and you know how to do this. Refractory stricture or a twist or secondary to severe twist, I think the best way is to send them for a surgeon. You should ask your colleague who's experienced with these type of cases. You tell them, listen, I tried my best. I dilated once and twice. They did not improve. I think you should take the patient for Roux-en-Y gastric bypass. I tell you why this is a very important, because I saw some cases that been dealt with a gastric bypass, but unfortunately the bypass was below the structure, at the level of the structure. So the patient comes back again with the same symptoms. You go endoscopically, you see above the anastomosis or the stoma, you see again angulation and twist. So the patient did not get any benefit from the gastric bypass. So just to mention this, surgeon has to be very experienced with these type of cases, and they should have dealt with these type of cases. So another complication that we see is a weight gain. We know that a gastric bypass is the gold standard for weight loss, but the weight regain is an issue for these type of patients. And this is the numbers: 93%, they maintain only 10% from their weight loss, and 70% they maintain 20%, and 40% they maintain 30% within the 3 to 5 years. So this is another issue. Patient who did gastric bypass, they regain weight, they come to you very sad, very disappointed because of weight regain. We all know that this is because some sort of food behavioral issue. They go and switch themselves from normal food to sweets and stuff like this. But again, there is another issue also. You as a surgeons, you know better than me what is the other causes. So how we can treat this patient? Always, I call it food behavioral changes is a very important. They should sit with a psychiatrist or psychotherapist, and really they should understand how to eat, what to eat, and when to eat. Medications is also, it's a good option. Saxenda is one of the medications that we use sometimes, but with a limited result, to be honest with you. Endoscopic intervention, I'll show with the next few slides what we do for these type of patients. Surgery is not a good option in some cases because they have a very small pouch, some adhesions, so the surgeons, they will not like to go and do surgery for these type of patients. So what we do this, we do the Touré procedure and pouch revision. Through the scope, the outlet reduction, endoscopy, we do it. I think I have a video here, but let's see if it's working. Yeah. So this is the animation. This is what we do, but just to show you the normal, how it should be, and then the abnormal. This is basically the normal anatomy after gastric bypass. This is the stoma after gastric bypass. The food goes in, stays in the pouch. Gradually, slowly will go to the small intestine, but with time, month after month, the stoma will increase in size, and this will cause some sort of hunger to the patients. They feel hungry all the time, and they want to eat more and more because the stoma size it's increased. And this is basically, you find it after 2-3 years of surgery. The patient will come to you, they will say, okay, I got my weight back, some of my weight back, and I start to eat more and more. So what we do the Touré procedure with over the stitch device. This is what we do. This is what we do. This is the anterior view of the gastric bypass. This is the posterior. This is the stoma. What we do is basically we reduce the stoma size to 8 to 12, and then we reduce the pouch size. We can also do this. This is the endoscopic view before and after. This is the device that we use. I'm not going to spend that much of time, but in general, over the stitch endoscopic suturing device, it can be used for many things. But unfortunately, this is a very expensive device. Otherwise, we can use it for stent fixation, perforation, leak, stoma reduction, pouch reduction, even colonic perforation, you can use it. But unfortunately, it's a very expensive device. It's about 1,600 KD, the cost of this device. So this is the downside of this device, but we do use it right now for the ESG, endoscopic sleeve gastroplasty. Your goal is to reduce the stoma to 8 to 12, and there is a different way of doing this. Either you can do it just by view and you are measuring with a scope, with a regular scope. The regular scope is usually 9 millimeter. And this is the way how we suture the stoma. There is a different way, different technique of how you can reduce the stoma. Either interrupted suturing better, or running, or you can use a different other modalities. Different gastroenterologists, different surgeons, they do it differently. We, myself and Professor Musa Khurshid, we do differently, and we have a good number of these type of cases, and we have a very good result for these type of cases. So there is a selected selection criteria for this type of patient: age, BMI, and the history of the previous surgery, and how much they weight loss and how much of weight they regained. Endoscopy is a very important. You have to measure the pouch, you have to measure the stoma. Is it really dilated? How big is the pouch size you have? Because you cannot play with your scope or your device inside if you have a very small stoma. So it's very dangerous for your patient. So you should have anesthesia. It's always under general anesthesia. It's a supine to left lateral position. You use an overtube to insert your device. The device can be very risky to the patient because you may lacerate the esophagus or causing bleeding or perforation. So then you evaluate and you go ahead and you start your procedure with a CO2 always, as I said in the beginning. This is what we do. We evaluate at the beginning. We always use an ABC argon plasma around the stoma. We do a very good argon plasma. We use it around the stoma, and then we start suturing. And this is basically what you see. This is before, and this is the after. After the procedure. And this is just I thought we'd share this video with you. This is what we do. This is one of our cases that we did, I think, a few years ago, maybe 1.5 years ago. This is a food residue, food bolus, so don't worry about it. And this is basically what we are doing right now. We start doing the ABC, and usually the ABC, you can tell how big is the stoma. It's huge. It's more than 2 centimeters for sure. So what we are going to do, we aggressively right now using the ABC around the stoma. And why we are using the argon plasma is basically to enhance the closure of the stoma after, or the healing of the stoma after using the suturing device. So we really spend a good time in terms of using the argon. This is the device, how we insert the device. You notice the overtube up there, always CO2. This is a very important. And then we start to suture. A different way, as I told you, you can use a different, whatever is comfortable for you. If you are familiar with this device, you can use whatever suturing way you like. So what we do, we pull the mucosa toward us, and then we start suturing. I'm just going to speed up this just to show you how we do it too. We are placing, I just want to show you a very interesting view here. Yes, I think now it's a good, now you will see this is the first suture. Basically, we can use 2 suturing, you can use 3, we always use reinforcement, what we call it. So we use one suture and we reinforce it with another one on top of the first one, just to be sure that it's not going to get loose after sometimes. You see the stoma right now is getting smaller and smaller. This is from the only one stitch, one suture. So it's really a very unique technique, to be honest with you. So this is the view, and we are going to place a second one, and then we reduce even the stoma size, the pouch size. So this is what we do for this. So okay, so another complication like a band and ring complication. This is basically, if you are talking about both VBG, we don't see much. We used to see that before, but right now, even now, even until a few days ago, I saw a case with a band, adjustable gastric band erosion eroded inside the stomach. So slipping is one of the dysfunction or complication, stenosis with a pouch dilatation, erosion, minor and major. What we mean by minor and major, at least, is it be less than 30% or more than 30%. The reason why they divided it this way, because if it's less than 30%, you cannot deal with it endoscopically, so you have to deal with it surgically rather than endoscopically. Symptoms is varies if it's slipping versus stenosis versus erosions, but most of them, they will have nausea, vomiting, weight regain, and abdominal pain. So we did, myself and Dr. Ali Said al-Musawi and some other colleagues, mainly myself and Dr. Ali, we did a few cases in Mubarak, and even in the private sector, we did cut the adjustable gastric band, specifically if it's eroded, with a lock inside the stomach. We used the specific device, which is like a Suhandra cutting device, we call it, with a wire. It's a metallic wire, but with a soft end. And I will show you how we do this right now. This is a video that we did it together. If you see the band right now, this is just a picture of the band, but the video will be showing another band that we removed in Salam Hospital. So be sure that the band is migrated more than 30%. And you can tell just by the view. Sorry, I will go back just to see. I'll just show you. So you can tell here that this is 100% is more than 30%. And if you see the lock, it's already eroded inside the stomach. This is the metallic wire. The metallic wire, usually we insert the metallic wire and you lube it over the gastric band. Then we insert both wires inside the metallic sheath. Like if you saw something that we use in the ERCB room, which is the Suhandra crushing basket, exactly the same technique. So you must place your wire not over the lock, because this will crack your wire. We place it slightly beside it, and then gradually, slowly we cut. See, you'll see the cut right now so cut, it's done. And then easily you will be able to remove the gastric band. Then once you cut it, Dr. Ali Said here, he is removing everything surgically, the catheter, and the rest is by surgical approach. So this is another way of dealing with erosion of the adjustable gastric band. So let's go for the leak right now, which is one of the most serious and life-threatening complication. We have been dealing with this since 2009, 2010. We did the first cases of post-bariatric leak. We dealt with it in Kuwait. The incidence is about 1 to 5%, but it depends from center to center. I think in Kuwait, I think we are within this range. I should say that 90% of leak patients, you will find the leak at the angle of Hess is just below the GE junction, and maybe even less than 1 centimeter. So it's a challenging way of treating these type of patients. As I said from the beginning, they are very critically ill. Some of them, they can present with different symptoms. The most common symptoms that they present is a shoulder pain, tachycardia, fever, abdominal pain, nausea, vomiting. So these type of patients, this type of symptoms they present. So time in etiology, it's a very important. We think in the literature is if it's less than 48, this is a mechanical or a technical issues like stapler failure, and this has happened to some of our colleagues. There was some sort of problem with the staplers. If it's more than 5 to 7 days, this is most likely related to ischemia. And we had cases, and you can tell endoscopically that there is ischemia because you will see the entire stapler line is ischemic, or at least 50%. I saw cases which is the entire stapler line is ischemic, and the stomach basically it's open totally. If it's more than 7 days, it's basically because of high intraluminal pressure, which is related to a twist or a stenosis or stricture. And to me, at least, this is the most common cause that I see. So how we treat this patient? These type of patients, they get admitted to under you guys, under the surgery. So the most important is stabilizing this patient. You must nutritionally support the patient, and you start antibiotics. Extremely important to do a drainage if it's possible, either or by intervention radiologist or by laparoscopy. So you must drain the collections there, specifically if they are very sick. You do not want to call your colleague from gastro to deal with this type of patient unless you did your job as a surgeon in terms of IV fluid, antibiotics, drainage, and the full support. Then you can call your colleague. Surgically or surgical treatment is a good option, but I noticed that most of the surgeons, they don't want to go in. Why? Because of friability of the tissue, because of the granulation. It's going to be a mess there. So, and the suturing is not going to take whatever you do, and you may harm the patient. You may close even the stomach for these type of patients. So endoscopy is a best option, I think, for these type of patients, specifically if you catch them early. This is the best time to deal with these type of patients. What you can do, you can cover the leak, you can close the leak, or you can drain the leak. This is what you can do for these type of patients, but this depends on when you saw the patient, what's the symptoms of the patient, and what you find endoscopically. So if you want to cover the leak, you have to think about stenting. There is no other modality to cover the leak. Stenting is different stent in the market. At least in Kuwait and some of our colleagues in Europe, they use at least the Ultraflex. This is the one in the top on the left. This is what we used at least for 5 to 6 years. We used the Ultraflex Stent, which is the partially covered. You see the covering from the middle, and it's uncovered at the tip, and both ends it's uncovered. This stent is a very good. We had an excellent result with this stent, but there is a big problem with the stent is when you are trying to remove this, because the granulation tissue will cover the entire uncovered proximal area, which is as the esophagus. To try to remove the stent, it's extremely difficult and can be very risky in terms of tearing the esophageal mucosa and causing perforation. So what Dr. Jacques Devier thought about at that time, he will follow up this patient, and he will insert the Ultraflex Stent, which is the one in the down on the left. He will insert this Ultraflex inside the Ultraflex. This is basically to enhance the granulation tissue or to release the granulation tissue by pressuring this area, and he will keep it for 2 weeks and then remove it. And this is what we did in Kuwait. We followed his steps, and we had a very, very successful time. And we were able to manage our patient this way for years. And then we end up with using the Beta Stent. This is the one in the middle. If you see, it's a fully covered stent. There is what we call it, it's a two wing. This is a wing and this is another wing. This is basically to prevent migration because this is a fully covered. So, but unfortunately, the result wasn't that great with this stent. Even with the closure of the leak wasn't that great with this stent. Within a few years, we switched. Most of us right now, we use the Mega Stent. This is the Mega Stent, which can be a different size in terms of diameter and length. This will be placed from the esophagus down to the small intestine, because it can come as 18 centimeter in length or 23 centimeter. So it's different length. And even the diameter can be 28, 30, 34, 36. So they diameter. So you have to be very careful. You may ask yourself right now why this diameter is very important, why they created this 30 and 30, 28, sorry, and 30 and 32 and 34. This is basically because if you have a dilated esophagus and you insert a very small diameter of the proximal stent, like 28, and you have a very dilated esophagus, you did not do anything for the patient. Patient will not get any benefit. So this is some pictures we'll show you. This is an old pictures that I have. This is one of the case that end up with a post-sleeve leak. And just a general thing to say is most of the leak that we see is a non-contained leak. Because contained leak is easy to manage, but this is most of them you see as here, you see the contrast is gushing in the abdomen. This is a very difficult, and most of these patients are very sick. So if you see there is a draining catheter here, and this is very important. And I usually tell the surgeons, do not remove your draining catheter. Even when I put the stent, even when the patient is doing extremely well, do not remove your draining catheter, because you don't know. If I remove the stent after 3, 4, 5, 6 weeks, whatever, you may find still there is a small leak. So what's gonna save your patient is draining catheter. This is what's gonna save our patient. But be sure it's placed on a right location, because some of cases we saw that's inserted inside the stomach and causing more trouble than improving the case. So this is a very tiny leak. You see here the very tiny opening. And if you notice that I'm using the cap here, this is the cap just to improve the vision for myself. And plus, it helps you to inject directly to the leak site. And even if you want to use another maneuver, another technique, not a stenting, for example, something else like an Ovesco clipping, you can use it with this. So this is the old stents that we use. This is the stent. This is Ultraflex Stent, the partially covered stent. We use it. This is after the insertion. You see there is no gushing of the contrast outside. And just a hint for you guys, you see the stent is a very smooth, is like a, like an L, very smooth. Patient who is having twist or angulation, you will not see this angle like this. It's going to be really twisted, and your stent will be even sometimes kinked severely to the level that even your contrast will not go down. And this is a proof for the surgeons to say, okay, listen, your case end up with twist or angulation. Even a nasojejunal tube, I will not be able to fix in certain cases. Does the stent will help in terms of dilating the angulation or twist? Most of the time, no, specifically if it's a huge or if it's a very severe angulation. This is the stent, how it looks like. This is the granulation. If you remember, I told you the granulation is very heavy. You can tell here, even you cannot see the proximal end of the stent. And try to find your thread or try to find the proximal end of the stent, and good luck if you can pull it like this. For sure you will tear the mucosa. Did this happen? Yes, it's happened with me. Once I pulled the stent and then I saw the esophageal mucosa that's coming out from the mouth of the patient. It's not good. It's totally not good. Thanks God my patient did not perforate. We inserted another stent. We left him for some time and we removed it. So this is inserting a polyflex stent inside the Ultraflex, again, just to release the granulation tissue. And then finally, this is how it looks. And finally, we remove both. So this is how we use the Mega Stent. So again, leak, and this is the leak, how it looks like. And this is the Mega Stent. If you notice the Mega Stent, it's really longer. Notice what I said just now. Notice the angulation in the middle here at the incisura level. Just notice the angulation, the kink of my stent. Even sometimes some gastroenterologist or a surgeon try to insert the stent, they will not be able to insert the stent because of angulation. And the stent gets broken inside the stomach, or the delivery system gets broken inside because of this severe kink that it's having, that it's like this, or even sometimes worse. This is how the Mega Stent looks like. What is the problem with the Mega Stent? I should say 99.9% of the patient who had a Mega Stent inserted, they end up with this at the end of the stent, at the distal end, which is basically, it's an ulcer, because the stent gets frictured with a duodenal mucosa, and the patient will have severe pain after a few weeks. Possible they may bleed from it, and they will have increased the saliva secretion, pain, colicky pain because of this ulcer at the end. This will heal if you remove the stent. Maybe it's gonna end up with some sort of polyp-like ulcerations is there and will be left. And it's hard to treat. This is the downside of this stent. This is the Beta Stent. It's different than the Mega Stent. This is the ulceration, how it looks like. The treatment of this ulcer, basically, you just put your patient with a high dose of proton pump inhibitor. Okay, so it's a very, very successful to close the leak. It's up to 80%. I think even to 85% it can close the leak. It's a very important to catch this patient is very early. If they are morbidly obese, it's going to be difficult to close the leak with a stent. Complication, it's a minor complication like bleeding, possible, as I said, ulcer. Stricture, usually at the esophagus where you place the proximal. This is we noticed this previously with the Ultraflex Stent and the Polyflex, the one that I mentioned at the beginning. The downside, again, I mentioned this, but with a partially covered stent, you will end up with stricture and possible injury of the esophagus. With a fully covered stent, you will end up with a high rate of migration and ulceration. Okay, so this is with acute leak, you dealt with, done, finish. So what about the cases that we inserted a stent, patient did very well, but after 4 weeks, you remove the stent, there is a still collection. It's contained collection like the one it's here. So you can have a few options. Either you leave it. Sometimes you can leave it and wait and see the patient if he develops any symptoms. Some patients, they don't develop any symptoms. They have like a diverticuli. It's like this one, and they do very well with it, you know, because it's whatever it goes inside, it's going to go back to the stomach. But sometimes this opening, the opening between the sleeve, the stomach, and the pouch is a very small. So patient will do well for a few days, then he will develop pain, maybe rigors, maybe fever, maybe shoulder pain, and this will cause an issue for him. We had a few cases from, you know, I had cases from Saudi Arabia, from Kuwait. So what we did is the following. We inserted 2 double pigtail stent, biliary stent, the one like this one. It's a very short one, like 4 centimeter or maximum 5 centimeter. We put one end inside the cavity and the other one inside the sleeve, the stomach. This is basically just to enhance the draining inside the sleeve, the stomach. And we leave it. We leave it for 4 to 6 months. This patient, you don't believe it. Sometimes they come to you and you will not find the stent and you will not find even the opening, because this will close slowly and try to push the stent inside the stomach and drop the stent inside the stomach, and the patient will be free of symptoms. Very successful, up to 78 in the major papers that have been published. So if does not improve and the patient still having symptoms, you try this and it's not improving, then you send them for your colleague, you know, for the surgeons to deal with. And I noticed the surgeons, they don't like to deal with these type of cases because they will end up most of these cases with open surgery, and it's going to be a mess, you know, lots of fibrosis, adhesions, and etc. So we as a gastroenterologist, we try our best to solve this problem as much as possible. So Obvisco, we have a very limited experience with this. I think we have maybe 8 to 10 cases that we dealt. If you have a very small opening from the beginning, you can see it. You can use the over-the-scope clipping system. This is how it looks like. It's basically over the scope. You can place it and you can deal with it. But this is you deal with it with a certain cases, with a very limited cases that I will mention right now. It's been approved already. This is a new class of endoscopic clip. So we usually use it for acute bleeding, for closure of the fistula and perforations, you know, but we tried it again for the chronic fistula. I think for a chronic fistula will be much better than acute leak, because acute is a very friable area. It's very hard to grab the tissue together with a clip. So it's better to stent this type of patient. But if you have a chronic fistula and it's a very tiny and you will be able to see the opening, so it's better to use the over-the-scope clipping system. It comes, the clip, it comes in different sizes. There is a mini and there is, you know, the regular clip, and there is a new one that we use it to fix the stent. If we are using esophageal stent and we want to prevent migration, we can use the stent fix type. As you see here, there is a different type of clip. There is, like we call it, you know, some of them esophageal, gastric, and duodenal, a different type. So you have to choose the right type. And basically you have the anchor and you have the twin grasper. The reason why I said just now it's about fibrotic tissue or chronic fistula, because you will be able to grab this with a twin grasper, or sometimes with an anchor. Anchor is sometimes very risky because you don't know what's behind this fistula. If you insert this inside the fistula, you may injure other organs like spleen or something. With a twin grasper, it's going to be much easier. You grab one side, like this one, like this image. You grab one side, and then you grab the other side. Okay, you grab them together, pull inside the cap, and you flare your scope. And here we go, you close the fistula. You have to be really experienced with this device to use it in a good way. Otherwise, you're just gonna flare up the clip, and you will not get any benefit from it. So, this is a different image of the leak, just to show you there is sometimes can be a very big, like the one in the corner here. You will not know which one is the lumen, the one in the right or in the one in the left. Which one is the leak? Is it in the right or in the left? So it can be very, very difficult. So this is over the scope that we used in one of our patients, and we were successful with this patient. Even she traveled abroad, and they told her this is a good job that's been done to the patient. She came back with nothing being done outside of Kuwait. Okay, so to end up about the leak, the way how I think about it, if you have a case suspicious of leak with the symptoms and patient unstable, you cannot think about it that he will go to the endoscopy room. It's better to take him to the OR, drain, fix the IV, central line, everything. Then you talk to your gastroenterologist. If the patient is very stable, then you can image him first. You can ask the intervention radiologist to insert a draining catheter if there is a possibility. Then you can discuss this with your colleague from gastro. So it really depends on the case by case, and there is a different variety of what you can use over the scope. Internal drainage, you can use different type of stents, a different modality of how we can treat this patient. So in conclusion, I think endotherapy has become the first-line therapy for most of post-bariatric complications like stricture, band, ring complications, and leaks. You need to have a multi-disciplinary therapy for these type of patient group or team. You have to discuss this with your surgeon, with your radiologist, with a gastroenterologist, and intensivist. You have a different variety of what you can do to this patient. Stenting, internal drainage, and bloods. We don't use it because it's made of pig. We don't have it in Kuwait. The treatment always from patient to patient is different. It's very important to interfere as soon as possible. Don't delay your patient, please. Otherwise, the successful rate of healing with a stenting will be way less. Endoscopy for these type of patient is a very efficient and very safe. As I said, team approach is extremely important. Thank you so much.
Thank you, Dr. Jabir, for a lovely session and for all the valuable information that you shared with us today. We have a few questions. So the first one is, how successful is transoral outlet reduction in reducing weight by numbers?
So I can read the questions here in front of me. How successful is Touré in reducing weight by numbers? We don't have a long experience, to be honest with you. We did just around 4 or 5 cases. Unfortunately, in Kuwait, we don't have a good follow-up for these type of patients. Our patient, they don't like the follow-up. So they just do the procedure and they disappear. Did you face any complication of post-Touré? No, not that I'm aware. I never had, or even Professor Musa, we never had any complications from Touré. At least to our knowledge, no one of our patients came back to us, or no one of our colleagues mentioned anything to us. How long do you keep the stent that is used for leak? Depends on what type of stent you are using. But if you are talking about Ultraflex, Polyflex, usually about 2 months. If you are talking about the Mega Stent, usually between 2 to 4 weeks. The reason why I remove it after 4 weeks, because of the ulcer that these patients they develop. It's a very risky ulcer, and it can perforate the small intestine. Thank you for this. My question is, what's your opinion regarding endoscopic steatomy too? Okay. So what type of stricture you are talking about? So treat post-sleeve stricture. So when I say stricture or stenosis, I mean at the incisura, because there is nothing to cut there. There either you treat with balloon dilatation, with an achalasia balloon dilatation, either you deal with it with a stenting, but from my experience, from my European colleagues' experience, a stent is not a good option, because once you remove it, the twist will come back or the stenosis will come back. So either endoscopic balloon dilatation or surgery. I try with my patients a few times. If they are not responding, usually between 2 to 3. If they are not responding, I tell them go to surgery. Even sometimes from the first time, I tell them just go for surgery. There is nothing I can offer you. The reason why, if it's a very tight structure, stenosis, or very severe twist, if you dilate them, you will perforate them.
Okay.
What is the success rate of reducing the stoma size endoscopically after? This is already, I answered this. I mentioned this.
Okay, thank you again, Dr. Jabir. It was a pleasure having you here with us today. And we look forward to having you again with us in future sessions, inshallah.
Thank you so much. Thank you. Goodbye.
Thank you. Okay, so the QR codes are going to be on the screen. You can see them on the screen right now. If you'd like to register for the next surgical fix session, it's going to be on liver lesions by our guest speaker from Oman, Dr. Yahya Al-Azri. Also, if you'd like to register for the next ABCs of Research session on the 1st of July with Dr. Sarah Lioha, you can go ahead and scan the QR code. And also, if you want to register for the surgical debates, please feel free to check out our social media outlets and our website or podcast. Also, you can scan the QR codes on the screen. Thank you everyone for attending, and we hope you enjoyed our session. We look forward to having you again with us in future sessions. Thank you.